We will assess the electrocardiography, electrooculogram, electromyogram, then sleep pattern, BP, pulse oximeter for any fall in saturation. From all these things, we can assess whether there is episodes of desaturation or apneic or hypopneic episodes in this child.
Was that done in this case?
It is not done in this case.
What are the other investigations you would like to do in this case? What are the investigations you would like to do?
For this child, I will do hemoglobin to rule out any anemia, then BT-CT to rule out coagulation disorder, then viral markers, blood grouping and matching, then TC-DC ESR to rule out an infection, then room air SpO2.
So,
then if the patient is having any symptoms of pulmonary artery hypertension, I will do ECG and echocardiography.
this patient you said is having infection, temperature. Would you take up this case for surgery?
No.
You said there is fever, no? No, there is no fever. So,
At present,
if
there
the
is no
patient is
fever.
having respiratory infection, let us say the patient is having running nose, would you take that case for?
No, I will not take up the case. I will take up the case only after 4 to 6 weeks.
No, is that correct? If there is running nose, you won't take up the case? When will you delay the case? When will you delay the case?
When there is fever more than 38 degrees Celsius, when there is signs of lower or upper respiratory tract infections like productive cough. In these conditions, we will, or the patient is not active, alert, or not taking feeds properly. In these conditions, we will not take. And if there is only mild discharge without any purulent sputum or secretions, we can take up the case.
So, if the patient is showing definite indications of infection with high fever, increased temperature above 38, purulent discharge, then you delay the case. Otherwise, you go ahead and do the case. That is okay. So respiratory mild infection is not a contraindication, absolute contraindication for not doing the case. So how will you, now you have the patient, what will be your plan of management in this case?
What are the unique airway challenges in patients undergoing adenotonsillectomy?
The challenges can be preoperative challenges, intraoperative challenges, and postoperative challenges. The pre-op challenges are this child is having enlarged tonsils and adenoids, so the child is more prone to have airway obstruction during induction, and also we can have difficulty during mask and ventilation and during laryngoscopy. And
what about after giving pre-medication?
Check.
Do you have any airway challenges?
After giving pre-medication, due to the sedation, there can be airway obstruction in these children.
Intraoperatively, what are the airway?
Intraoperatively also, there can be chances of endotracheal tube obstruction, compression, displacement, or accidental extubation during insertion and removal of the boiled Davis cap. There can be chances of bronchospasm in this child. And postoperatively also, there can be airway edema leading to airway obstruction, and there can be laryngospasm in the child. Okay.
So how will you go ahead now? You have a patient for tonsillectomy, adenotonsillectomy. What is your plan management?
My plan of management is general anesthesia with controlled ventilation with the endotracheal tube, preferably ring Adair Elvin tube.
You can go ahead and tell us how you are going to do. How many have you done? Have you done? Enough, no? Tell us what you do.
So on the pre-op day, I will visit the child and try to make a good rapport with the child. And I will explain the NILPER oral guidelines to the child. I'll explain the procedure.
With the child and the mother, with the parents.
Then I will explain the procedure and the complications that may arouse due to the procedure and our anesthesia. And I will, on the day of surgery, I will pre-medicate the child with a syrup chloral hydrate 5 ml.
How will you, what drug will you use for pre-medication?
Chloral hydrate syrup.
Why do you say chloral hydrate? Which is better, midazolam or chloral hydrate?
What's the advantage of midazolam? What's the advantage of chloral hydrate?
The midazolam is, it produces sedation, reduces anxiety, it avoids antegrade amnesia.
Midazolam will produce anticlimatic amnesia and sedation.
And
What is the
sedation.
duration? What is the onset of action of midazolam?
20 minutes,
What about chloral hydrate?
30 to 40 minutes.
What are the drawbacks of chloral hydrate?
It can cause nausea, vomiting.
Prolonged sedation. You know,
Sedation.
midazolam acts, it's a short-acting one. Which one would you prefer, midazolam or which one? Which one have you used in this case?
In our institution, we are using
Using chloral. Okay,
hydrate.
then yes, continue this.
So I will give chloral hydrate 5 ml, 500 mg per 5 ml syrup to this child in a monitored environment with facilities for ventilation and oxygenation in case of any emergency. Then I will check my OT. I will preset the temperature of OT to 27 degrees Celsius.
Would you use anti-silocoque?
Yes, sir.
Have you said no? Do you want to use?
Yes, after shifting to the OT.
Okay, after the okay.
Then I will check the workstation, circuits, oxygen cylinders, suction apparatus. Then I will make sure that there are 2 working laryngoscopes with adequately sized endotracheal tubes, masks. Then make sure that all emergency drugs are available. Then I will set the IV fluid ringer lactate. Then I will load the drugs. Then I will see whether the child is adequately sedated. And if the child is adequately sedated, I will bring the child to the OT, and in the OT I will attach the monitors, and if there is an IV access I will start IV fluids, and if there is an IV cannula is present I will give injection
Who is putting the IV cannula use? Are you going to use? What are you going to do? Are you going to put in an IV cannula preoperatively?
In our institution usually they will come with IV cannula.
They come with IV cannula.
IV cannula.
Okay. So they put it in the ward and come.
Ward and.
Okay.
So if there is IV cannula, I will give injection glycopyrrolate, 0.01 mg per kilogram injection on and.
Why did you choose glycopyrrolate and not atropine?
The rate of rise in heart rate is less when compared to atropine. Then it does not cause any central nervous system adverse effects.
Is it important in pediatrics, central nervous system adverse? In old age it is important. In pediatrics, I don't think it is very important. Okay then.
When you are selecting glycopyrrolate, what's the special advantage of giving glycopyrrolate?
Secretions, it will reduce the secretions.
Okay.
So then I will pre-oxygenate the child with 100% oxygen with the Jackson-Rees circuit.
Have you attached the monitors?
Yes, madam. I will attach pulse oximeter probe, NIBP cuff of appropriate size, then ECG and precordial stethoscope for this child. Then I will give injection fentanyl,
What is preemptive analgesia? Are you planning preemptive analgesia for the child?
Yes, we can give preemptive analgesia. We can give injection paracetamol IV 10 to 15 mg per kilogram for this child, or ibuprofen syrup can be given in the dose of 5 mg per kg for this child.
So it is an IV injection, intravenous?
Intravenous injection.
Okay.
Okay. I will induce a child with injection propofol 2 to 2.5 mg per kilogram, and then I will support the child if the child goes into apnea, and then I will give injection vecuronium 0.1 mg per kilogram, and after 3 minutes I will intubate the child with RA tube of 5 mm internal diameter, and I will make sure that
I'm concerned about pain. Did you give anything for alleviating the pain due to propofol?
Injection lignocaine 2% without preservative can be given.
Can be given or you will give?
I will give before giving propofol. After intubation, I will make sure that it is endotracheal intubation by looking at the ET-CO2 and by 5-point auscultation method. Then I will maintain anesthesia with nitrous oxide, oxygen and sevoflurane and intermittent dosages of muscle relaxant to this child.
Let us say you are inducing with inhalationally. There is no IV line. Give it. How will you induce this patient?
If the child is having no IV line and child is uncooperative, I will do with inhalational induction with the sevoflurane after priming the circuit with the sevoflurane. Before shifting the child to OT, I will prime the Jackson-Rees circuit with the sevoflurane 8% and fresh gas flow of 6 liter with the nitrous oxide and oxygen in a ratio of 2:1 for 3 minutes. And after priming, I shift the child to the OT and attach monitors like ECG.
How will you prime? I didn't understand. How will you prime the circuit?
Prime with fresh gas flow of 6 liter plus sevoflurane 8%.
So would you occlude the?
Occlude the patient in.
Yeah. And then, what is the other method? This is
This
vital.
The incremental
Is there any other method of induction?
Incremental method of inhalational induction.
Pardon?
Incremental method.
Oh, okay.
In this,
Which one? What are the advantages of high concentration induction and?
By inhalation and induction, we can maintain the spontaneous ventilation, then smooth and rapid induction and recovery.
What is the advantage of using high concentration of sevoflurane and inducing the patient?
Rapid induction of anesthesia we will get.
Rapid induction is one. Can you skip something, some patient response, something? The excitement stage, okay, by using high concentration. Okay. So you would prefer a high concentration, yes. Then go ahead now. What will you do then?
Then I will attach monitors such as.
No, while putting the gag, what are your concern? The surgeon is putting a Boyles-Davis gag. What are your concerns?
There will be kinking and obstruction of the endotracheal tube or displacement.
Before that, let us ask what about the tubes? RA tube.
RA tube, kinking and obstruction of the RA tube, displacement and accidental extubation of the RA tube while putting an insertion of the gag.
What's the advantage of RA tube?
Kinking is less. Kinking and compression is less compared to normal endotracheal tube.
Any disadvantage for using RA tube, Ashwati?
Suctioning is not possible with suctioning is difficult with RA tube.
Difficult to insert the stillet through the RA tube, and the distance of insertion is already predetermined. So the depth of insertion we cannot adjust the depth of insertion due to the predetermined bending in the RA tube.
Then I will attach monitors such as pulse oximetry probe, ECG, end-tidal carbon dioxide, NIBP, and precordial stat. Then once the eyelash reflex is lost, I will put an IV cannula and secure. Then after that, I will decreases the dial of the inhalational agent to 2%.
She's saying yes. Okay, let us say you have finished the case, the surgeon has finished the case, and on extubation, patient develops stridor. So tell us about that. What is the reason? What are the risk factors for stridor? What are the risk factors?
The risk factors for a stridor are airway edema, then secretions, blood, all these things can trigger a stridor in this child. And during extubation, if there is
Sir is asking about the risk factors for development of perioperative respiratory adverse events.
Airway edema, secretions, blood.
How will you know it is stridor? How can you diagnose stridor? What are the signs of stridor? Obstruction, airway obstruction.
Air entry will be reduced bilaterally. There will be increase in airway pressures. There will be fall in saturation. Then EtCO2 also.
Now, by looking at the patient, what are the signs of respiratory difficulty in respiration? What are the signs of respiratory distress?
After extubation, there can be tachypnea can be there.
The tachypnea is there, yes.
What about the chest movements?
Will be decreased bilaterally.
Inspection?
Then on auscultation also, reduced air entry will be there, or absent air entry will be there. Saturation fall will be there.
Would you not see paradoxical respiration, retrosternal?
Retrosternal.
all that.
Supraclavicular, infraclavicular hollowing,
Yeah.
retrosternal.
So,
Intercostal
what is
introinsular
what is respiratory failure? These are the signs of respiratory distress. What is the difference between respiratory failure and respiratory distress? When do you say respiratory failure? Can you clinically diagnose respiratory failure?
There will be absence of any respiratory movements.
Okay. How will you manage this case? Patient has developed stridor. Patient is desaturating rapidly. What will you do?
I will give 100% oxygen for this child. Then I will give a head tilt, chin lift and jaw thrust to open up the airway. Then I can go for Lassen's maneuver. Painful stimulation can also cause opening of the airway. Then if not responding, I can increase the depth of anesthesia by injection propofol.
Now, how can you increase the depth of anesthesia? Because patient is in total spasm of the vocal cords. How can you increase the depth of anesthesia? What will you do?
Propofol, bronchodilator,
Before that, first thing
Will you try to ventilate the patient with
bag and mask ventilation.
Would you not ask for a second help?
I will call for help.
You must call for help because why do you want help here? Because you have to hold the mask by both hands and someone else has to give the
bag and mask ventilation.
What ventilation? What is
Positive pressure ventilation can be given.
CPAP.
CPAP.
Sometimes the CPAP would open up the upper airway. So one person has to hold the mask, another person. So you need help first. And then if it doesn't relieve the spasm, CPAP, then what is your next action? You have given 100% oxygen, you've given CPAP, nothing is happening, patient is still desaturating. What would you do?
Injection propofol or injection ketamine can be tried. After
what
that,
will you do?
I will give injection succinyl scoline 1 to 2 mg per kilogram and will intubate the child.
So you won't try propofol first, would you? She told, yeah. So what is the dose of propofol? How much will you give here?
0.5 mg per kg can be given.
Not can be. You are
give
going to give, what is the weight of the patient?
12 kg.
So,
6 mg IV I will give 6 mg IV propofol.
Okay, up to 1 milligram per kilogram body weight. So doesn't open, still there is desaturation. Then you will think of
intubation.
Giving
Succinylcholine.
Succinylcholine, yeah. How much?
1 to 2 mg per kilogram. That is 20.
Will you give succinylcholine 1 to 2 milligram per kilogram body weight for relieving the stridor?
Or 0.5 mg per kg. For relieving stridor, I can give 0.5 mg per kg succinylcholine.
Yes. Then?
I will intubate the child if the child is not responding.
Yeah, you have intubated the child. Then what will you do? How will you prevent laryngospasm during this extubation time? Next, you have intubated now, no? You have given succinylcholine and intubated. So, again, you will have to extubate. How will you extubate next?
I will extubate the patient after reversing the neuroprocedure when the patient is fully awake and spontaneous respiration is adequate and all the airway reflexes are appeared. Then in a head down and left lateral position, I will extubate the patient.
Yeah, patient should be fully awake. Okay, then only you can extubate the patient. Yes. Suppose you have shifted the patient to the post-operative ward, and after a few hours, you get a call that patient is spitting out blood, and you are called. How will you manage this situation?
The post-tonsillectomy bleeding is the most common complication seen after tonsillectomy. So I will reassess the child and I will check the consciousness level in the child. Then
what are the anesthetic concerns in post-tonsillectomy bleeding patients?
It is an emergency surgery, so the child may be in full stomach, either due to the swallowing of blood or due to the intake of food from the ward. Then there can be difficult airway due to the airway edema, due to the presence of blood and secretions. And then the child will be in hypovolemia. And also there can be residual effects of sedatives and anesthetic drugs used during the previous surgery. So these are the anesthetic challenges. Then I will assess the child. I will check the hemoglobin level of the child. Then
the parents and the child may be very anxious. You should attend that also.
Then I will look for capillary refill time. Then I will.
How will you look for capillary refill?
By pressing at the distal phalanx, we can see blanching of the skin, and then release the pressure and see whether the blood flow returns normally within 2 to 3 seconds.
How will you check hydration? Is it important?
Yes.
How will you check?
We can look for hydration in the tongue, eyes, skin.
Skin turgor.
Urine. Then urine output can be asked from the mother.
Okay. And then what will you do?
Then I will resuscitate the child with the crystalloids, 15 to 20 ml per kilogram. And then I will ask for blood and blood products. Then I will set the OT and then shift the patient to the OT, attach monitors. Then I will give injection glycopyrrolate 0.2.
Now, how will you arrange the OT? Let us see how are you going to prepare the OT before you take up?
I will check the workstation, then cylinders, Jackson Reed circuits. Then I will make sure that suction apparatus is working properly with the wide bore suction catheter. Then I will make sure that all emergency drugs, then 2 working laryngoscopes, mask, bougie, stillet, video laryngoscope are all available. Then I will set the fluids and set the temperature to 27 degrees Celsius, and then we'll shift the child to the OT.
So would you ask the surgeon to be in the theater?
Yes.
That is important. No, the surgeon should be. Why do you want the surgeon in the theater before you start?
This is an anticipated case of difficult airway. If we cannot secure the airway, we can ask the help of surgeon for tracheostomy.
He can also help you because, okay. What are the concerns here? Patient is bleeding. You are at the head end. What are the concerns?
Since the patient is bleeding, there will be difficulty in the laryngoscopic view of the child. Then there can be increased edema. These all can impair the bag and mask ventilation, laryngoscopy, intubation in this child. So,
what else? How will you prevent? How will you go ahead with this?
I will give injection glycopyrrolate 0.01 mg per kilogram, injection ondansetron 0.1 mg.
Patient is already tachycardic. So you want to give glycopyrrolate when the patient is bleeding?
Then I will pre-oxygenate the child in left lateral position and then go for a rapid sequence induction for this child. And
how is rapid sequence induction different in a child when compared to an adult? Or what is modified rapid sequence induction?
In modified rapid sequence induction, we will give small volume tidal breaths after giving succinyl choline.
You will give after giving succinyl choline?
We will give small volume tidal volume breaths with limited pressure.
You keep ventilating the patient with low tidal volumes. Okay. That is not done in adults. Okay. So you want to do a modified
rapid sequence induction.
Would you put pressure?
Yes,
cricoid pressure?
Pressure will be given.
How is it different in a child when compared to an adult? Is there any difference? At least theoretical difference.
In adult, we will give 10 Newton force.
What is the force? Theoretical force used?
10 Newton
in adult?
Initially and followed by 13 Newton after giving succinyl choline.
In pediatrics, in this child, how is it different? Would you use the same force?
Lesser force will be given in pediatric patient.
Okay. So you use lesser force and then what will you do? How will you conduct modified rapid sequence?
According to the hemodynamic status of the child, I will prefer either propofol or injection ketamine. If the child is hemodynamically stable, I will give pre-calculated dose of propofol in the dose of 2.5 mg per kilogram. And then I will give a small volume, tidal volume breaths to the child, and I will intubate the child with injection succinylcholine 1 to 2 mg per kilogram, and after 1 minute, I will intubate the child.
Okay.
What about the tubes you select?
R8 tube of size 5
What about
mm.
size I'm asking.
5 mm
You should
internal
know the
diameter.
size of the tube used previously. Then one lesser size you should set.
So the tube is in. What will you do next?
Then I will make sure that it is endotracheal by 5-point auscultation method and looking at the ET-CO2 graph. Then I will maintain anesthesia with sevoflurane and oxygen nitrous.
Would you do anything to the stomach?
I can put a nasogastric tube after
Visual,
intubation.
under vision.
Under vision.
So you shouldn't poke it because it could increase the bleeding. Blindly you shouldn't put it. Under vision, you put in a tube and try to suck it, but could be difficult sometimes. Okay, then?
Then I will arrange, according to the hemodynamic status, I will resuscitate the child with the blood products if required. And I will give intra-op analgesia with the injection paracetamol 10 to 15 mg per kilogram body weight.
Okay. In pre-medication, is there any role for dexamethasone?
And dexamethasone can be given to reduce post-op nausea and vomiting, and also it reduces the pain of the child.
So
Edema also it decreases.
Yeah, it reduces edema, number one. Number two?
Post-op nausea, vomiting, it decreases.
Yes.
And also it has analgesic effect.
Okay.
Injection dexamethasone 0.2 to 0.3 mg per kilogram can be given intraoperatively.
Why don't you say that in the pre-medication? Would you are you routinely using dexamethasone?
Yes.
Pre-medication. What about antiemetics?
Injection ondansetron can be given, or intraoperatively injection dexmedetomidine can be given as infusion to reduce the pain and also to reduce post-op nausea and vomiting.
So pre-medication, would you use an antiemetic? You didn't say an antiemetic. Would you use it? Are you using it routinely?
Yes, glycoandamicin.
You can add that. It's the pre-medication. So now the patient, what are the analgesics? Would post-operative analgesia? How will you manage that?
Analgesia can relieved by injection paracetamol 10 to 15 mg per kg IV infusion can be given. Then oral paracetamol can be given. Then or preemptive analgesia like infiltration of the tonsillar bed with
So post-operatively you want to give paracetamol. What else? You want to give paracetamol. What else you will give? That too intravenously you said, no?
Intravenous.
What else you want to give?
Paracetamol suppository can be given.
Either IV or suppository.
Then infiltration of the tonsillar bed with the local anesthetics, 2% lignocaine or 5% ropiocane.
How is the absorption per rectally? You said per rectally.
Per rectal.
What is the suppository? How is it? How is it absorbed? Is it absorbed well? How do you know? It's very erratic. Though you use it very erratic, yes. There is an IV line. You can give it intravenously. Okay, orally you cannot give because it is immediately following the surgery. So either rectally or rectal, very erratic absorption, and therefore you won't know whether it acts. So what else you will give? You will give paracetamol. What else you want to give?
Infiltration of the tonsillar bed with the local anesthetics.
Pardon?
Infiltration of the tonsillar bed with the local anesthetics.
Yeah, surgeon would have done it. You must ask the surgeon to that. Okay.
Then intranasal dexmedetomidine 1 microgram per kilogram.
Post-operatively, I am asking about do you give dexmedetomidine post-operatively?
Yes.
No, what else you will give?
The
Diclofenac suppository can be given 1.5 mg per
Okay,
kilogram.
you want to use an NSAID. Okay. NSAID may be given, though theoretically said to produce increased bleeding. Among the NSAIDs, which one would you prefer?
Diclofenac can be given for this child. We will avoid ketorolac.
Paracetamol and diclofenac.
Diclofenac.
Preemptively, I think you have given ibuprofen, isn't it?
Ibuprofen.
Ibuprofen. Okay, that would be a better agent. So you give it every 3 hours. Start with paracetamol. After 3 hours, give an NSAID, and every 3 hours patient will get an NSAID, get an analgesic. Okay. What about opioids? Would you like to give opioids?
We will avoid opioids for this child because of increased chance of airway collapsibility in these children.
Opioids
For
are
the monitored environment, we can give short doses of fentanyl 1 to 2 microgram per kilogram if required.
opioids are
Sorry
generally
for the
avoided.
interruption. Sir, the time is over.
So we'll wind up here. Both of you have done well.
Thank you, sir.
Thank you, sir.
She didn't get chance because you were answering all the time. So anyway, good.
Thank you, doctors, for this enlightening session. After every case discussion, if any of the audience require clarification, you may kindly clear it after the same.
Yeah, good morning. I just want to clarify something about the management of laryngospasm. I thought that a couple of things I need to point out. Most of the points were mentioned, but intermittent positive pressure ventilation should be avoided when there is either a complete or an incomplete laryngospasm, because if you apply positive pressure against a closed glottis, all the air is going to go into the stomach, and then you'll have a problem of regurgitation and possible aspiration. So no positive pressure ventilation. Just keep the adjustable pressure limiting valve of the circuit that you're using completely closed. Give a large enough flow to keep the bag distended. If you wish, you can give a little pressure on the bag. So you're applying CPAP through a completely filled circuit. No IPPV. The second thing I thought we'll point out was the dose of succinylcholine you mentioned was for intubation, not for managing a laryngospasm. 0.2 to 0.5 milligram per kg is more than enough just to break the laryngospasm. If you give a full intubating dose, you'll again have to wait for a very long time for the patient to come out of the relax. Small dose is fine. And I think, Pankaj, did I forget anything?
And the second thing is you need not intubate the patient again. You'll land up with the same thing with extubation. So you just need to do bag and mask ventilation at that time and till the scoline effect goes off. That's it. You don't need to put a tube back in. So extubation, laryngospasm, if you have given scoline, it should be 0.1 to 0.2 milligrams per kg. And then when the patient is relieved, just give bag and mask, slow ventilations, and let the child come out of it. Don't have to intubate. Right. And Larson's maneuver, I'm not sure how much it works, but the best way is that when you give CPAP, make sure you have a controlled valve there to what pressures you are giving. Otherwise, you will end up inflating the stomach, and that will again cause desaturation in a small child. So in case you are using it, make sure you have a nasogastric tube there so that the entire, if you have put the air into the stomach, comes out of it and it is deflated. And perhaps a lot of drugs were being used. If you have used dexamethasone, this is good enough as a preoperative. You don't have to add ondansetron and all those things to the patient. If you're given IV paracetamol, it should be okay. Or you can give rectal paracetamol suppository right in the beginning. So that itself is quite good enough. So too many drugs are not actually required. A combination of maximum 2 drugs should be there. So I would rather put a pre-op paracetamol suppository and give DEXA, because that gives you a very good action as far as nausea, vomiting, and pain relief is concerned. Thank you.